Okay, esteemed members, good evening, and thank you for joining us today. If you can hear me, just send a message in the chat and let us know which branch of PSK you're joining us from. All right, thank you. I see some response. Thank you, Dr. Dan from Nairobi, Dr. June from Central, Dr. Anthony from Coast Branch, welcome. Dr. Bernard from North Rift, Dr. Nadia from Nairobi, Dr. Marete from Nairobi, karibu. From Southeastern, Dr. Philip Kioko, welcome. So meanwhile, as we wait for 2 more minutes, kindly ensure that you go to the PPB portal and subscribe to the event. Remember, the sooner you subscribe to the event on the PPB portal, the sooner you get the CPD tokens. So kindly ensure that you do that. All right, I think we'll get started now. Good evening once again, and thank you for joining us today. Today's webinar is on enhancing patient outcomes in type 2 diabetes, and this is through the pharmacist-led intervention. And we're glad to have AstraZeneca, which is the organization that is sponsoring this event. And we'll be having our speaker, Dr. Achaya, who I'll introduce later, who's going to take us through this topic. So just once again, a reminder, if you just joined us, kindly ensure that you take a minute of your time, go to the PPB portal and subscribe to this event and use the keyword T2DM, and you should be able to find the event easily on the portal. Just a few ground rules. Just to remind you that you'll be muted during the entire course of this session. And if you have any questions, kindly use the Q&A tab, and the speakers are going to respond to the questions immediately after the session. This session is being recorded and it will be made available on the PPB and the PSK YouTube page. So at this point, I'd like to introduce our speaker for today, Dr. Chaya. So Dr. Chaya is a consultant physician, endocrinologist at MP Shah Hospital, Nairobi, Kenya, and also the chair for the National Diabetes Kenya. She won the Tommy Adamson Award and Cogs Prize for the best student at University of Nairobi. She trained in diabetology and endocrinology at Aintree University Hospital, Liverpool, and Glasgow Royal Infirmary, UK from 1995 to 2000. She's been involved in writing the first national diabetes strategy and clinical guidelines for Kenya. Aside from that, she's the committee member of the Kenya NCD Alliance and also the Kenyan representative for the Pan-African Endocrine Society. She's published and presented widely at national and international diabetes and endocrine conferences. She's supervised many postgraduate students for their thesis. She's passionate about diabetes advocacy and training all cadres of healthcare workers and setting up diabetes clinics in rural Kenya and regularly organizing patient empowerment workshops. Aside from that, she enjoys writing poetry, painting, singing, cooking, and dancing. She's also the former lecturer at University of Nairobi and still honorary lecturer there and past faculty at Aga Khan University Hospital, Nairobi. Aside from that, she's also a past secretary of the Kenya Association of Physicians. So at this point, I'd like to welcome Dr. Chaya. If you can hear me, Dr. Chaya.
Thank you, Dr. Hezron, and good evening, everybody. Thank you, so many of you, for joining in just before Easter. And I'm very happy to be presenting to you such a vast topic about pharmacist-led intervention in type 2 diabetes. I'm just going to start sharing my slides. So you let me know once you can see them. And thank you to AstraZeneca for giving me this opportunity to present such an important topic. So are you able to see my slides and hear me well, Hezron?
That's it. And the slides are very clear. Thank you.
Perfect. So this is a topic that's very close to me. I grew up as a little girl watching my father, who is a retired pharmacist now, managing patients very passionately, Dr. Butt, who is now in Scotland, but he's been all over Kenya, working through at different pharmacies, including the Kenyatta National Hospital. I think it was called King Edward or King George, some colonial name. So, and other pharmacies throughout Kenya. So yeah, as a little girl, I was very inspired to see him passionately managing patients and giving them, giving them advice. And I think the pharmacist plays a very important role in any chronic condition, because patients go up to pharmacies and ask questions, and there is this rapport between a patient and a pharmacist. So I'm really happy to be presenting this important topic today. And this is a disclaimer from AstraZeneca, and I have honorarium for this talk tonight. And my other disclaimer is I will talk about diabetes till the cows come home. So I will try and take you through, fasten your seatbelt. I'm going to take you through lots of slides in the time, and I'm happy to share my slides as well with anyone who wants them. So diabetes, type 2, type 1, any type, is popcorning globally, nationally, in Africa, and for various reasons. It's a lifestyle condition. And if you look at the epidemiology from the IDF Atlas, the graph is just going upwards at a scary rate. So currently there are 537, 543, people are still arguing, how many people do we have living worldwide with diabetes? Not every country has a national register, but we're just climbing upwards, and COVID even added to those figures. People with impaired glucose tolerance are even more, and they're just brewing to get diabetes tomorrow. And by 2030, 2040, it's going to be more. And then they're going to be more and more and more. And what can we do to slow down this epidemic? Because it's costly. And again, if you look at the IDF Atlas, Africa is winning the Olympic medals when it comes to the boom. So if you look at the rest of the world, where budgets are kinder, they're not increasing as much. If you look at Europe, you look at America, the increase is 16%. It's more modest. But if you look at Africa, we are way ahead with a postulated increase 84% between 2017 and 2045. So we really need to see what we can do. And this is not just diabetes, this is all the NCDs. So with the 537 million people living with diabetes, there is mortality involved. There is cardiovascular, outcomes, chronic kidney disease. People are really struggling to pay for dialysis. They're struggling to pay the consequences of strokes and heart attacks. And this doesn't need to be the picture. And we need to see what we can do. What can pharmacists do when patients are coming in to pick up their medications? Where can interventions make a difference? Where can education and empowerment make a difference? So we need to really think out of the box and see what we can do, especially here with our resource limited, what can we do here in this part of the world? Diabetes affects men, women, people living in rural Kenya, urban Kenya, and now the divide is, as Nairobi keeps increasing its environs, where is the divide between rural and urban? So, and then this burden is increasing on families because people are getting it at a younger age. Healthcare systems are getting burdened. The society is getting burdened, and for people with diabetes, especially type 2, it can have a wide-ranging impact on their lives. Not just physical health, being emotional well-being. People are very shy to talk about their mental, state of health, but people miss days of work, not just because they have an amputation, but also because they just can't wake up and go to work. Of course, with all the polypharmacy involved, as pharmacists, the cost of a prescription. Type 2 diabetes is due to many, pathophysiology. So somebody will not be on one medication. They might be on 4 different oral anti-diabetic medications. Then they are on a statin. They are on 2 or 3 antihypertensives. They will have neuropathy. So they are on something for that. And the bills just pile up. And this is something you can't stop. You can't stop the medication. It affects patients' leisure activities. That looks like padel. Nowadays in Nairobi, if you're not playing padel or paddle, you're not in vogue. But it affects people's leisure activities. You have neuropathy, you can't play. Work and studies, school children are being affected. People going to work are being affected. Relationships. Erectile dysfunction is a real thing, whether it's in males or sexual health in females. Pregnancy, polycystic ovarian syndrome is part of type 2 diabetes, the whole bubble. So everything is being affected, and we really need to look at the holistic picture. Now, Africa at a glance, younger people are being affected. These are just figures. It's really looking at the tip of the iceberg. The iceberg goes lower down. The MENA region, Middle East and North Africa have a higher prevalence against South Africa, 9.2. Now, if you look at figures like, Nigeria is 3.4, Kenya is 3.7, but when we go and collect data, Mukurweini, 11%. The coastal belt, again in Kenya, you go to Coast Province, it's higher, 10%. The urban areas of Nairobi, the highlands, central belt, it's not 3.7%. So these are anecdotal figures. So we know the reality on the ground is much more than what IDF Atlas or even what is being quoted. And we really need to take as advocates, we really need to do something. Again, there are so many factors that come underway, the culture, how people are, the health-seeking behavior, and we really need to take this on as a public health concern. If you look at the expenditure, yes, it's something to talk about. Ethiopia has some figures on impaired glucose tolerance. I think in Kenya, it's time to look towards our young Turks and say, look, let's get our studies out there, because if you know how many people have impaired a glucose tolerance, we can do something. 53%, if you look at the stepwise survey, it was a wake-up call. 53% of our hospital admissions are due to non-communicable diseases. So this is diabetes, hypertension, cardiovascular disease, stroke, cancers. And out of this, a big chunk is due to diabetes type 2. 80 to 90% of our patients, even here in Kenya, have type 2 diabetes, again, largely preventable. So let's do something to prevent this. In the year 2000, when I came back from UK, Dr. Patrick Bugwa did a study at Kenyatta National Hospital, and this study is still being quoted up to date. And I'm sure this figure is no longer true. We are in 2025. We are losing 1/3 of our patients from diabetic ketoacidosis at Kenyatta National Hospital. This is not acceptable. If 1 in 3 people are not leaving the hospital alive because of diabetic ketoacidosis, because of a study done in the year 2000, it's very embarrassing when this study is getting quoted at every international conference. So somebody needs to follow up on this study to say that we are not losing so many cases to decay. When we sub-analyze the data, not every mortality at KNH was from decay. There were patients that were being clocked and parked over weekends. Some of them had HHS, they had hypoglycemia, they had MIs, but they had been missed, and just the initial diagnosis at casualty was DKA. So the picture is not as dismal as it was in the year 2000, and we really need to change these figures. We are getting more and more of childhood obesity, which is a forerunner to type 2 diabetes. We are seeing more cases of gestational diabetes and diabetes in pregnancy. Maybe we are looking for it more, which is a good thing. Our dialysis centers are being financed by patients with diabetes and hypertension. And if we can just look for microalbumin, we can control sugars, cholesterol, and hypertension better. We can have better renal salvage. We need more epidemiologic data because that will be the driver for prevention of the complications. We need a central register for diabetes. The health-seeking behavior of Kenyans, one person might go to more than one clinic. They might go to people who are not healthcare practitioners because of the billboards that are going up on Gong Road and that are on trees that promise cures to things that may not actually be a cure. So again, if we had a central register, we would capture our patients better and be able to guide them better. However, we are proud that we've launched our national strategy and guidelines for diabetes and also had been able to have an update to them. Our essential drugs list has all the latest diabetes medication in them. And we've also launched our NCD strategy and guidelines. We have advocacy arms in all these groups. There is still work to be done, but we are plodding along nicely and we are doing work. We should not lose momentum. And I think if all the associations came together and we are trying to work together, we can achieve a lot more. And I would really be happy if, we've been training online as Diabetes Kenya and IDF study group. We trained over around 2,000 clinical officers during the COVID pandemic online training. It would be great if we can roll out more and more training. Online is a great way of training. And if all of us were talking the same language, I think there is a lot that can be achieved in terms of utopian control for the patients. We've had our unique challenges, but we also have achieved quite a lot. Some of the key drivers of diabetes growth has been people not, being aware in the past, but I find nowadays we have patients who are much more empowered. Similarly with healthcare workers, again, sometimes to adopt a healthier lifestyle, it's when patients have myths and they have, a psychological influences that are coming in the way. Also, issues with availability, accessibility, and affordability of medication and supplies comes in the way. So if we can help our patients to overcome some of these, I think these will be very important milestones. This is just a pictorial representation of some of the guidelines we have managed to get, and some of these are also available online. Again, like I won't have time to go through too much epidemiology, but basically, with the numbers of people living with diabetes, when we look at the people with desired outcomes and the people with good control, we had done a study across all the hospitals in Nairobi, and both private and public. I was one of the researchers in this study, and we've also published this in the Lancet. We had a similar, like it was not very good in terms of control of diabetes, HbA1c, hypertension, and lipid control. And I think we can improve on this in terms of what we can achieve. Now, diabetes is there's a high global burden in emerging countries. So of the 90% of people who have type 2 diabetes worldwide, about 50% don't even know that they have the type 2 diabetes, so they're undiagnosed, so there's work to be done. 80% are living in emerging countries, and we're not getting our targets of HbA1c, fasting sugar, postprandial sugar, hypertension is not controlled, and lipids are not controlled. So we need to get our patients in the first year so that legacy, we can get, control in the first year. It makes all the difference in terms of preventing both macrovascular events as well as mortality. And there are studies to show that individualizing our patients makes a huge difference as well. So if we have a patient who's elderly, who has lots of complications, one foot is literally in the grave, has cancer, then we can be less stringent with control. But if we have a young patient with a long life expectancy, we have to be more stringent in our control. So one shoe size does not fit all. And as healthcare providers, we really have to look at the whole picture when we are dealing with patients. Sometimes I have couples who come to see me, and I really have to tell them, look, both of you are different, your spouses, or I have siblings coming to see me, or a mother and a child who are both diabetic, and I have to tell them, look, this is what is ideal for you, this is what is ideal for you, and I'm not going to give the same prescription to both of you, so you have to listen to each one's individual profile. Diabetes type 2 is associated with increased risk of acute coronary syndrome. In fact, type 2 diabetes has been called a coronary equivalent. So people with diabetes get heart complications earlier, and I explain that to my patients. I have a model in my office where I show them what the arteries look like, what the heart looks like, what the kidneys look like, what the eyes look like. So they're more compliant with going to see the ophthalmologist. They're more compliant with taking the statins, and they're more compliant with allowing us to look at their feet. So heart failure is another thing that patients are not aware of until we talk to them. There are unmet needs in patients with diabetes. And again, we have to screen for the unmet needs, like looking for the albumin, looking at the renal function, and also the polypharmacy. Sometimes the patient will say, why are you increasing my medication? So if we explain to them, this is your target HbA1c. If we don't achieve it, this is what is going to happen in the next 10 years. Increased risk of heart attack, stroke, heart failure, nephropathy. And these are the medications that may prevent it. The patient becomes your partner in the care. Now, heart failure is a very silent tip of that iceberg. It's a very common comorbidity in patients with type 2 diabetes. And many times the symptoms creep up on the patients. And we really need to tell our patients about heart failure, about CKD. We need to tell them how we are going to screen for it. And by the time you're waiting for the legs to be swollen and the face to be swollen, it's late. So there are ways we can screen for it. The STENO-2 trial taught us that it's important to do intensive treatment, which is beyond glycemic control. So the HbA1c, the triglycerides, the LDL, the blood pressure. So if you look at the conventional therapy and you look at the intensive therapy, you really saved on years. The patients lived 8 years longer when you did intensive therapy in terms of holistic management, and this has been proved. So 7.9 years of life gain is really worth it when you do intensive therapy. A patient-centered approach is very, very important, where the patient is at the center of your management, but you really have to reach out, and everybody has to talk the same language, whether it's the nutritionist, the podiatrist, the pharmacist, the doctor, the patient's family members, the community health worker, everybody. If it's a child in school, the teacher has to be on board. If it's the employer, they all have to be on board. Now, there are patient factors that impact glycemic control. The patient sometimes feels you're really being cruel when you're saying, don't eat this, don't eat that. So they don't like the word diet. So I don't use the word diet because the first three letters are die. So you can use the word like medical nutrition therapy. Exercise. Many patients think of exercise as gym. They think of exercise as expensive. They think of exercise as punishment. Kenyans like to dance. You can tell them dancing is a form of exercise, and you see their faces light up. Walking to work, they're saving on the expenses and the jams and everything. So you can actually suggest to them they can exercise with bags of flour and put them in they can put flour, the unga in the bags put unga in the cloth bags and do weightlifting. They can put the Coca-Cola bottle. I'm not advertising Coca-Cola, but if you fill that up with water, it's very easy to hold in the middle because of the shape of the bottle. And that becomes dumbbells for lifting, for resistance exercises to prevent sarcopenia. Stress can impact on a patient's sugar control, other intercurrent illness, whether it's a UTI or it's COVID or it's any other intercurrent illness, some surgery. So all this can impact on the patient's HbA1c, and we need to explain to them these are hiccups that will come. Adherence, compliance are big issues. Sometimes the patient won't take the metformin if it's giving them GIT side effects, or if it's not XR. Many patients take it before meals. So just as the pharmacist, you can make a big difference by telling them this medication is before meals, this medication is after meals. Sometimes patients just don't take the medications because of the side effects, and doctors are too busy to explain to them how to take the medication. So if we work together as a team, it really has a huge, good outcome. Now, this slide was presented at the EST conference in 2018 by Professor Chantal Matthew, a remarkable colleague. This slide alone, she took 1 hour going through this slide. I'm not going to take 1 hour, I promise you, but these patient-centered management, where you have SMART goals, specific, measurable, achievable, realistic, time limited, where at every appointment, whether it's a 3-monthly appointment, at every point of contact with your patient, you're discussing with your patient, are you okay? Is there anything bothering you? Are you taking your medications? compliance, adherence. Are you understanding? Sometimes we have elderly people, we have deaf people, they haven't heard what we have said. So if I see somebody in my clinic with somebody who has accompanied the patient, I always ask them, would you like the person with you coming inside? It doesn't have to be a family member. Many elderly people come with their care, their healthcare support, the people who are looking after them. And many times these are the people who are dishing out the medication to them. They are the ones cooking for them. They're helping them with their footwear. So it's nice if these people come in with them with the permission of the patient, and talking to them, they remember, they have the diaries with the sugar and the blood pressure. So it's nice to have somebody sitting in with the patient to whom you can reinforce your advice, or a family member as well with the permission of the patient. The decision making has to be shared. The patient has to be involved in your decisions, or the family member if the patient is going to forget. Many patients with diabetes get dementia as they get older and they forget. You have to empower your patient. They have to have the glucometer. They have to know how often they have to measure. Somebody with type 2 diabetes doesn't need to measure 7 times a day. Their fingers are, hurting. How often should they measure? Some patients are measuring 5 hours after a meal. That measurement is useless. So telling them measuring just before a meal, then another time measuring 2 hours after a meal. The seventh point of measurement, what I call the miscellaneous value in the 7 series of sugar measurement, is when they feel unwell. So if they are sweaty, they are dizzying in the middle of the night, if they break out in a sweat, they should have that column in their diary to measure a sugar when they don't feel well. That empowers the patient for behavior change, what to do when they have a hypo, what to do when they have a hyper. Do they take an extra medication? Do they take an extra shot of insulin? Do they have a quick, a sweet or some sugar in water or glucose? What do they do when they don't feel well? Sick day information, travel information, and the diabetes educators are very good at providing this information as well. But we as healthcare providers can also provide this quick, tips to patients so that they know what to do in emergency. Sometimes when a patient is having a hypoglycemia, they forget everything we have told them. So it's always good to share this information with the patient's support system, whether it's the person who's working with them, their driver, their family member. It's good if more than one person has this information. Emotional well-being is very important. So a patient who's depressed will not be compliant or adherent. So always look at your patient, how they're sitting. If they're sitting like this, they're not making eye contact, just find out what is happening to your patient. They will not volunteer information. A patient who comes singing, hey, I'm down, I'm depressed, might just be attention seeking. The real depressed patient will have other body language. You will know that if you know your patient, you'll know they are not okay. And as pharmacists, your patients come to you regularly to pick up the medication. So you will pick up if something is wrong with them. So please know when to tell them to go to their doctor or their psychologist or their psychiatrist. We are all together in this, and it's for the total good of the patient that we are doing this. We can't keep photocopy pasting the same prescription. If the sugar is high, the pressure is high, the pressure is low, something is not right, the prescription has to change. It's dynamic. Nothing is carved in stone. Sometimes there is lack of clarity over what is good glycemic control. If somebody has kidney impairment, their parameters are different. If a patient is pregnant, their parameters are different. During Ramadan, I give different prescriptions to my patient. This is suhoor and iftar prescription. So we have to be very clear. We can't be ambiguous with our patients. So you have to tell your patients, and if you think they'll forget, just write it on a paper and give them the paper. Or for most patients, I tell them to keep a diary where I write, these are my blood pressure, give them a range. This is my sugar, fasting between 5 to 6.5, below 5 is not good for you. Postprandial up to 11 is okay, 10 to 11 or 9 to 11 is good. HbA1c in this range. So monitoring. Then sometimes patients are very overwhelmed. And then when do they see other specialists? When is it time to refer to a nephrologist, a cardiologist, an ophthalmologist, a nutritionist, a psychologist? Patients do get overwhelmed. And again, everything costs money. So sometimes if you're working in Wajir or Mandera, you might not even have all these people. So you might be the one doing this for them. So again, as time goes on, the beta cells will fail. There'll be insulin resistance. Sometimes the medication will give the patient weight gain, whether it's insulin or sulfonylurea. There'll be fears of hypoglycemia. Patients are so scared about hypoglycemia. The care you give your patients has to be respectful. It has to be individualized to the patient preferences and needs. You have to value what decisions the patient makes. It has to be enabling, empowering, and there has to be dignity, compassion, and respect. The language we use, you can't just go saying, oh, you're going to go on insulin, oh, you're going to die, you're going to be amputated, you're going to have this. We can't. We have to. Type 2 diabetes is a progressive condition. We have to work with the patient. It doesn't matter how tired we are, how bad a day we are having, how busy we are. This patient is really afraid of all the complications. They're afraid of what finances they're going to be spending on their condition, and we really have to work with them. Again, this is not individualized. The LDL might be 1.4 with somebody who has had a heart attack, or their family members have had multiple cardiac issues. This is just a guideline. We want to raise HDLs. We want to reduce the triglycerides. The different associations, ADA, IDF, SEMSA is a South African. We also have our own guidelines in Kenya now. So these are just like nowadays we are being told even 120/70 is a better guideline for blood pressure. Now, the glycemic pentad is something I really like. I borrowed this slide from my colleague, Dr. Sanjay Kalra. So before, people were talking about the triangle of care, the HbA1c, the fasting sugar, and the postprandial sugar. But why I like the pentad or the star, we need to talk about glycemic variability or time in range, because when patients yo-yo, hypo, hyper, they'll get more complications, and the quality of life. What is the point of having excellent sugars, but the patient is depressed, or the patient has insomnia, or the patient is worried about their financial status, or the patient is undergoing a divorce, or the patient has other issues, the patient has a wound? So this is something as healthcare practitioners we shy away from. We should not shy away from. You should ask the patient, is everything okay at home? Is everything okay in the bedroom? These are important for the patient. Find out if it's a lady of reproductive age. Is she on contraception? Does she want a family? Is everything okay on that grounds? Because we are dealing with human beings with human feelings and emotions. I know it takes a little bit longer, but a happy patient is a healthy patient. Now, the reason why we have polypharmacy, it's not because we have shares in pharmaceutical companies. Type 2 diabetes is a very complex condition. It is caused by the aggregatus 11. You've heard of the ominous octet. The octet just got more complex. 4 more things were added. So type 2 diabetes is caused by beta cell dysfunction. So there's reduced insulin because of the beta cell dysfunction. There is an incretin effect in the K and L cells of the intestine. That is where the newer molecules come in. There is an alpha cell defect with the glucagon being up regulated, which is where the incretins and the pramlintide come in, which we don't use a lot because of the side effect of pramlintide. Then the fourth defect is in the adipose tissue. So that is where the metformin and the thiazolidinediones come in. So there is increased production of glucose in the breakdown of the adipose tissue. Then the muscle cells are involved. The liver is involved. Liver really works overnight to produce more glucose overnight. That's why you find the dawn effect. As the sun rises, so does the sugar. The brain, the satiety is also affected through the dopamine and the ghrelin and the leptin. That's why obesity and satiety come in with diabetes. Then if you go to number 8, the colon biome, that's why probiotics are really coming in. And that's how the incretins and metformin, they work through the colonic area. Immune dysregulation, you've seen patients with type 2 diabetes, their CRP is high. Whenever we check ESR, CRP, inflammation plays a big role. And that's why patients with diabetes get more psoriasis, they get more ulcerative colitis, they have more of Hashimoto's, they have all the autoimmune conditions more. Type 2 diabetes, just like type 1 diabetes, is an autoimmune condition. Then if you look at the stomach and the small intestine, again, there is issues with glucose reabsorption there. It's not absorbed as well. So you get, that's where the GLP-1 agonists come in. Then when you go to number 11, the kidney, these are the new kids on the block. So reabsorption of sugar through the proximal tubule, I'll be talking about that in a minute. SGLT2 inhibitors come in there. So you can see how complex the pathophysiology. This used to be a very good question, essay question, short essay question worth about 6 to 10 marks in the essays for both postgraduate and undergraduate at the University of Nairobi. Now, how do the anti-hyperglycemic agents work? So you can see all of them work in different ways. That's why if we use combination therapy, we use early combination therapy, we can even put our patients in remission. I don't like using the word reversal because then patients think it goes away forever. I know bariatric surgery does a bit of that. the newer agents do that. But if we can catch our patients early, we can give them the hope of remission. I know there'll be a lot of questions on that in the question. Again, remission of diabetes is a 1 hour lecture. Most of my slides are 1 hour lecture. So today I'm just giving you a taster on diabetes. Now, the cardiovascular risk reduction in adults with type 2 diabetes, cardiovascular is a big thing. We are losing patients to cardiovascular disease. When we talk about health equity against populations, it's very difficult to give everybody equality, but we are striving for equality. We have to be democratic. How do we give this democracy medically to our patients across all our counties? We have to screen for cardiovascular disease. We have to change lifestyles. If you want to change somebody's lifestyle, it's very difficult to change the lifestyle of a 60-year-old or a 70-year-old, but we can still try. Start at the school, start at younger ages, have those billboards out there. I'm so happy to see milk being advertised this, and I'm happy the other happiness coming from other unhealthy things has gone now. Happiness has to come from within. It has to come from exercise. It has to come from traditional diets. It has to come from spending time with the elderly. It has to come from good practices. Blood pressure management, lipid management, statins. There's so many ways we need to really go back to the drawing board. How are we going to socially determine health? And that is not something we might be able to do as healthcare practitioners. We need politicians. We need the social workers. It's a really, really big Herculean task, but it's time we start talking across to everybody, even bankers, so that we have a healthy nation. Now, looking at guidelines, the 2020 AAC-SC guideline looks at the HbA1c at the beginning. That's why I like this guideline. And then the entry A1c is important. Lifestyle comes in, and then besides metformin, they give you a choice what to add in. It gives you a chance to revisit every 3 months, so the prescription keeps changing. It's very dynamic, and then looks at the progression of the disease. Again, if you just discuss guidelines, it's a whole lecture in its own right, but this looks at patients if they have cardiovascular disease, CKD, and then it recommends SGLT2 inhibitors or GLP-1 analogs earlier on. So in this guideline, the SGLT2 is recommended independent of glycemic control in high cardiovascular risk patient. So even if your A1C is not high, if your patients are at high risk, please offer them the SGLT2 inhibitor or the GLP-1 analog. This is just a zooming in type 2 diabetes drug naive patients. You can still add the SGLT2 inhibitor even prior to the metformin if the patient has a coronary risk equivalent or a renal equivalent. These are just pillars. I borrowed this from the ADA, where besides glycemic management, don't forget the BP, the lipid, and protection of cardiovascular and kidney benefits. Now, this bubble here shows you actually things that are above and overboard, where to reduce cardiovascular risk patients, you have to look at other things. Statin, the dyslipidemia, it's not just statin, we have other molecules as well. Antiplatelet therapy in the patients who need it, antihypertensive therapy, weight loss and lifestyle intervention has to start from day one, even in impaired glucose tolerance before the diabetes comes in, and glycemic control. This is the 2022 guideline where the first line therapy depends on the comorbidities. Again, people need to also look at whether the patient can afford what is available. And then the high risk cardiovascular risk comes in, heart failure risk, CKD, where you either use an SGLT2 inhibitor or you use your GLP-1 analog. To minimize hypoglycemia, you can use any of the medications that don't cause hypoglycemia. To minimize weight gain, the GLP-1 analog or the SGLT2 inhibitor is considered. And then the guideline just tells you how you can go down. So you can see insulin has been pushed a bit lower down because we have such a huge pharmacologic armamentarium. Now, since the ECHO study had issues, the FDA in 2008 mandated cardiovascular outcome trials, and that has been very useful for us in terms of patient safety. When we took our Hippocrates oath, we said do no harm, and then we do good. Now, diabetes is a leading cause of cardiovascular disease, kidney failure, blindness, and lower limb amputation. And we have to be aware of this every time we are writing our prescription. We want to prevent heart failure and MI. We want to prevent kidney failure. We don't want our patients to spend all their life savings on dialysis or renal replacement therapy or transplants, which are so difficult to get, donor kidneys and everything, the cost. Amputations of limbs is real. And again, it really impacts so negatively on patients. There's also a diabetic hand where patients get issues with their hands. It's something Professor Gill used to talk about when I was working with him in Liverpool. And we've seen that happening as well. Retinopathy is a real, issue we have to worry about in our patients. I've seen young type 1s also getting really bad retinopathy with crippling issues on their vision. And cataracts also happen earlier in our patients and stroke. So I don't need to talk about the complications. Some patients need insulin despite the whole pharmacologic armamentarium. And the clock starts sticking not just at the onset of hyperglycemia, but with macrovascular complications before the onset of hyperglycemia. There are some patients who will need insulin in type 2 diabetes when there's ketoacidosis or very high sugars. Sometimes insulin is needed just short term in surgery, during pregnancy, people who are on steroids, and when there's failure of combination therapy. This is just a slide to show you that now with technology, we have the pens, we have smaller needles. That was the old needle. My grandmother used to be injected by my mom with that big needle. And that's one of the reasons I decided to do diabetes and endocrinology. And the pumps, you can see the guy, he has muscles to carry that backpack of a pump. Now you've seen the pumps are so tiny. So technology has really made a difference. Again, a talk on insulin is an hour's lecture. Now, despite all the improvements, mortality is still high in our patients with type 2 diabetes. So we are clearly missing something. And that is why I said networking makes all the difference, because somewhere our patients, whether they're getting medications free, like when I was training in the UK and the NHS was providing free medication, still people were slipping through the net. They were getting the complications. So it's not always about cost. We sing about cost, but something somewhere gets missed. We must remember to screen for things like sleep apnea in our patients. One of the studies I supervised was on sleep apnea, where I was at the University of Nairobi, and a lot of our patients have sleep apnea and type 2 diabetes. You just need to use a Berlin questionnaire or simple scoring. Sleep studies are expensive. So, questions about snoring and questions about, people being tired, having headaches. Sarcopenia is very real. So sarcopenia is when there's muscle weakness. People with diabetes can't get up. It's treatable, and you don't need any expensive tests to look for it, but it's a real issue in our patients with diabetes, and it really it causes falls and fractures. So we need to look for sarcopenia in our patients. We need to address psychosocial and mental health issues. Erectile dysfunction is something the male patients will never talk about. I don't know if they talk to pharmacists, but with doctors, my male patients say, by the way, they talk about it as they are getting up to go. So it's something we always ask, how are things? Do you need help? And when a male patient has erectile dysfunction, it means also there are issues with their heart. So we need to discuss it. We need to give them the phosphodiesterase inhibitors even daily at a low dose, and then give them a higher dose when they need to perform. Again, there are vulnerable groups like teenagers. They have a lot of psychosocial issues. There are people in the slums that are struggling with so many things. So we need to help them, the underprivileged group, pregnant women, elderly. There are special vulnerable groups that need special attention. Gestational diabetes and diabetes in pregnancy is a topic in its own right. Overcoming psychological insulin resistance and real insulin resistance. Again, we need to empower these people. There are education and patient empowerment support groups in Kenya, and they're doing really well. So we just need to connect. The teenage group and type 1 diabetes have their own support group, and they have meetings and online chat. So that's really good as well. There is now more and more of an openness to gadgets and CGM use. Currently, as we are talking, we are doing an online training. IDF and Diabetes Kenya is doing an online training for CGM, and this is open to any healthcare practitioner. So those of you who are interested, please get in touch with me. There is a lot of training going on online nowadays, and then you get your points for these trainings. So it's good to have to have these trainings, because it helps you to help the patients. Again, advocacy and sustainability of strips. Many patients find the strips very expensive to use. So how often should you be testing? Glucometers, the CGM device, again, sustainability, availability, and the medication. So the SGLT2 inhibitors are a family of glucose transporters which prevent reabsorption of glucose from the kidney at the proximal tubule. Those are the common ones available here. We don't have the sotagliflozin, we don't have the original. And with the EU GMP, I think we have to be really careful when we are prescribing which generic. We have to be sure what we are prescribing. Now, the incretin defects, there's a cartoon there showing what it does in terms of the liver, the pancreas, the brain, and the GIT side effects. There are benefits with the GLP-1 analogs in terms of postprandial sugars and the satiety. Now, the SGLT2 inhibitors like dapagliflozin inhibit the SGLT2 by an insulin-independent mechanism, and that is why they don't cause hypoglycemia. So they are on autopilot. When the sugars reach a certain value, they actually switch off. And like dapagliflozin is extremely potent for SGLT2 versus SGLT2-1, whereas sotagliflozin is selective for both SGLT2 and SGLT1. So basically, you lose 70 grams a day. In most people with of sugar is lost through the renal tubules. Now, these molecules, this is a slide by Inzuki et al. These molecules work with novel pathways, and this has been based on all the trials that have been done. So there's reduction in albuminuria, which is why there's renal salvage. The uric acid goes down. In fact, when we check patients' uric acids, even without giving febuxostat or allopurinol, the levels go down. HDL is increased and triglycerides go up. The LDL cholesterol that goes up is the high density one, so we're not too worried. The oxidative stress goes down, and then the weight of the patients goes down and visceral adiposity goes down. Blood pressure and arterial stiffness also goes down. So we find there is cardiovascular benefits at many levels. So hyperglycemia goes down, natriuresis is improved, diuresis is improved, and the arterial stiffness goes down as well. So the SGL2 inhibition modifies several cardiovascular risk factors via all these multiple mechanisms. And in the process, this, the Agarose 11 I was showing is almost like copy pasting what they do to the Agarose 11. So multiple metabolic factors, there are benefits. And this is just a repeat of the cartoon I'd shown earlier with the organs. So there are multiple benefits in terms of pathophysiologic effects of type 2 diabetes, weight loss, blood pressure reduction, waist circumference reduction. In fact, nowadays, we don't use BMI in obesity. We prefer the waist circumference reduction. And then there's cardiovascular benefits as well. And there's so many trials that are showing in real life studies that efficacy and safety data, like even Foxica with insulin, is very safe. Now, YODA means year of drug administration. This is just a very busy slide showing you the EMPA-REG, CANVAS, DECLARE, VERTIS, DAPA heart failure, EMPEROR reduced soloist scored credence, all the various trials to show how many patients there were, what happened with heart failure, how many were on statins, the major cardiovascular outcomes, mortality. It's a very, very busy slide. And then I've just highlighted the DECLARE TIMI heart failure, the CKD to show you the benefits. Now, when the EMPA-REG trial results were first presented in Stockholm in 2016, I was present in the room. And even as endocrinologists, we were not aware of these results. So when these slides were shown for the very first time, we were all shocked, stunned, and overwhelmed. And people were in tears and screaming and shouting. There was a 10-minute standing ovation when the EMPA-REG results were first shown to the audience, that how can one molecule start separating even within a few weeks, what benefits is it doing for people with diabetes? And the SGLT2 inhibitors have been, the new kids on the block have changed the lives of patients. It has given them longer life expectancy. Very soon the DECLARE TIMI came out, and the DECLARE TIMI actually had more patients. So whereas EMPA-REG had 4,000 patients, this trial, real life trial, had 17,160 patients. Now, the reason why the trials are different, in the EMPA-REG, 99% of patients had established cardiovascular disease. In the DECLARE TIMI, there was 60% of patients who had risk factors, as in they were diabetic, but they didn't have established cardiovascular disease. So there were differences in the trial. 10 milligrams of dapagliflozin. This is just a summary. And then the EGFR, most of the patients in the DECLARE had normal renal function. And DECLARE showed very similar similar results to EMPA-REG in terms of renal benefits, cardiovascular benefits. increased life expectancy. This is the first time an anti-diabetic agent was showing that patients are living longer. Imagine if somebody told you can live longer, you can see your grandchildren graduate. This is like a life changer, a game changer for people living with diabetes. And dapagliflozin is the only anti-diabetic agent. In the declare they were in the DAPA heart failure. They had patients who are not diabetic. That's why the cardiologists and the nephrologists have stolen this medication from us diabetologists. They're using the SGLT2 inhibitors in non-diabetics for renal and cardiac protection. And in patients who are not diabetic, dapagliflozin is actually preventing diabetes in our patients. So now the same way metformin and acarbose prevent diabetes, dapagliflozin is preventing diabetes in patients as well. Now, DECLARE showed dapagliflozin prevented heart failure in type 2 diabetes population and resulted all the major cardiovascular events, whether it's MI or heart failure. And in terms of, everybody's always talking about UTIs and side effects, and that's why they were hesitant to prescribe it. But look at this, the UTIs, the placebo and DAPA-10 had the same number, 1.5. In fact, the placebo had slightly more. The Fournier's gangrene was much more in the placebo group. So the only signaling where there was more in terms of DAPA was genital infections. Now, the fracture that people are worried about with canagliflozin and the amputations, this was not seen with dapagliflozin or empagliflozin. So that is not a class effect. If you want to reduce the genital infections in your patients, this is what I do in my practice. So the amputation DKA fractures was not significantly higher in the DAPA group. This is what I'm trying to tell you. If you want to reduce the genital infections where there was a slightly higher signaling, but it was not statistically significant, you can actually tell your patients when they come to get the medication from you at the pharmacy, in case the doctor hasn't told them, that they can change their sanitation hygiene. So when they go for a short cold, they need to either wash with water or wipe with a wet wipe. And you will reduce the number of genital infections that the patients get as well. There was no hypoglycemic episodes in the patients, and you are seeing that patients were really, even at primary prevention level, they were really getting benefits in terms of cardiovascular events as well as renal events. So advantages of dapagliflozin or Forxiga or any SGLT2 inhibitor is cardiovascular risk reduction, renal protection, heart failure progression, durable glucose lowering at all stages of disease without causing hypoglycemia. You can mix it with any oral anti-diabetic agent, including insulin, weight loss, which is something we're striving for in our patients, blood pressure lowering, and patient satisfaction. My patients are very happy when they are on this medication. So DECLARE is the largest, broadest, and longest. These patients were followed up much longer than EMPA-REG or CANVAS, defines cardiorenal benefits of this class of anti-diabetic agents. Now, this is just a slide to show you the benefit of DECLARE TIMI 58 in a broader population of patients who had better renal function and better cardiac function. Now, heart failure is a continuum, as is CKD. And of course, we have to ask our patients to stop smoking as well. We have to check for microalbuminuria, and we have to refer to our colleagues as and when needed. There is a huge unmet need in our patients with heart failure because people with diabetes have 2.5 to 3 times higher risk of developing heart failure. But the SGLT2 inhibitors like dapagliflozin as shown in the DAPA-HF trial, once they're put on this, we can prevent heart failure in them. And this is whether it's HFrEF or HFpEF. And this is the only DAPA-HF. Dapagliflozin is the first and largest SGLT2 trial to successfully improve outcomes and symptoms. And this is why the cardiologists love this medication. And we're always fighting that this is our medicine with them, yeah? So with the DAPA heart failure trial, there was successful reduction in hospitalization for heart failure, cardiovascular death, as well as renal benefits. And it was very well tolerated in the patients. So this is just a summary of DAPA heart failure, reduction in cardiovascular death, heart failure worsening, all-cause death, as well as renal benefits, and pro-BNP and everything went down. If you look at all these trials, if you look at the forest plot curve, everything is to the left, which shows you that whichever major trial was done, everything is to the left, and that means all these are favorable. Every international association recommends SGLT2 inhibitors for patients with type 2 diabetes and heart failure, okay, because of the outcome trials. So whichever international organization you're looking at, IDF, Diabetes Canada, EAST, and our local, our local organization. Like I told you, onset of new onset diabetes, dapagliflozin is the only medication that prevents new onset diabetes in the diabetes naive patients. There are also new trials coming out that are showing that dapagliflozin is the only SGLT2 inhibitor that is preventing dementia in patients. Now, patients with diabetes are at high risk of kidney disease because of the pathophysiology of the nature of diabetes. And again, the DAPA-CKD showed that patients who are and the declared TME58, the Credence as well as the Emperor trial, all these showed that these SGLT2 inhibitors, dapagliflozin and the SGLT2 inhibitors slowed down renal progression. So DAPA-CKD met all the primary and secondary endpoints with patients with CKD with or without type 2 diabetes. So there was a reduction in the albuminuria and an improvement in the eGFR. Okay. Now, when you start your patients on an SGLT inhibitor, the eGFR will initially drop in the first 2 weeks and then get better. So don't panic if the creatinine goes up and the eGFR drops. It's a transient thing that will occur. So you have to reassure your patients, maybe not to panic if that happens. So SGLT2 inhibitors are recommended in our patients. The cutoff of the eGFR is 30, but off-label now in the newer studies, we are even using it in patients with lower eGFRs. We don't stop them if they're already on it and the eGFR drops. And even in our dialysis patients, we are using it. Now, diabetes in the elderly, what are the challenges? Our elderly patients are hard of hearing. Some of them have dentures, they're not eating. We don't really have geriatricians in Kenya, so we have to wear the caps of a geriatrician. The way the creatinine is may not be accurate. Elderly patients are really afraid of using insulin. They may be living alone. They're worried about hypoglycemia with the long-acting sulfonylureas and insulin. So SGLT2 inhibitors have helped us to fill in that niche with the elderly patients. So we have to be very careful how we manage. We have found elderly patients dead in bed, because of low sugars. So we really, really have to take into account the hidden pitfalls, hearing, visual impairment. When they're using the needle and syringe, they have not known how much to inject. Dementia, depression, all these are unique to our elderly patients. Again, diabetes and depression, even young people are depressed. After COVID, we had so many depressed patients. So a depressed patient will not be adherent or compliant, and diabetes and depression really go hand in hand. So you as pharmacists are more likely to pick up depression than we are, because the same patient and the families are coming to you. So psychological disorders, anxiety, depression, insomnia, these really contribute to medical outcomes, and we have to work together to help our patients. Hypoglycemia is real. Seizures, weight gain leads to defensive eating, cardiovascular complications due to autonomic neuropathy causing the hypoglycemia. Recurrent hypoglycemia causes dementia. Quality of life, patients are really afraid when they have hypoglycemia. Some of them need hospitalization, they don't have insurance. Patients can go in a coma. So we need to use agents that don't cause hypoglycemia. Now, despite all the compelling evidence, all the studies, even in the West, even in the NHS where medication is free, people are still, there is a clinician inertia. People are still, after metformin, using sulfonylureas. They are using the DPP4 inhibitors. They are not switching to the anti-diabetic agent that will salvage kidneys, that will salvage the renal function, that will prevent diabetes in a non-diabetic, that will prevent dementia. So I don't know whether it's because of comfort prescribing, because of some lethargy, but we really need to switch to therapies that have proven benefit, and we really need to see what is best for the patient. And sometimes it's not about cost. If you look, you're a pharmacist, you know the cost of medication, you know the cost of, what medicine, you know the cost of dialysis. So we really need to take everything into account, and life years of the patient and quality of life of the patient, consequences of hypoglycemia, consequences of renal failure. Diabetes is not a one-man or a one-woman show. There is a multidisciplinary team involved. We have to respect each other. We have to pick up the phone and communicate with each other. I apologize. In my disclaimer, I should have said about my handwriting. Us doctors have horrible handwriting, and we are so sorry for that. So you guys have to interpret what we have written, and apologies for that. But we need to talk to each other, network, talk, suggest to each other what to do, how to do. You are part of this team as pharmacists. We are part of the team. We need to see how we can get more people on board, and we can only do it with continuous CMEs, continuous training. Mental health professionals, we forget them, but they're part of it. Social workers, nutritionists, nurse practitioners, the diabetes educators are doing a fantastic job. When I came back from UK, we didn't have diabetes educators. We got them trained, we got them in. Now we have diabetes educators helping our patients. And we just need to think out of boxes. The school nurses are really good as well as managing our patients with the type 1 diabetes. And I think the sky is the limit. Sometimes patients' sugars are not being controlled, so it could be some endocrine condition. They could be having acromegaly if they're sweating. It's not all sweating is a hypoglycemia. So, look at the appearance, acromegaly, skin tags, insulin resistance, PCOS, if it's a young girl, periods are irregular. So please think there could be something else. If they have skin rashes, it could be a glucagonoma, hemochromatosis, thyrotoxicosis. Sometimes it's something else that is contributing. There are people who even abuse insulin to lose weight or other reasons. Choosing between the different regimens, it's a trade-off. Should I use this? Should I use that? What are the side effects? What can I combine with what? You would not want to combine a sulfonylurea with insulin. It's dangerous, but you can safely combine an SGLT2 with metformin. You can combine this with that. If the patient has gastrointestinal side effects, what can you do to reduce? So really look at always think of what the patient is complaining about, because if they have side effects, they won't use them. See what you can trade off. I don't think I've ever written an alpha glucose inhibitor for my patients. It's not even appearing in the guidelines. There is a paradigm shift towards combination therapy, initiating the SGLT2 inhibitors earlier. We really have to move with the times, and we have to learn to coexist. I am because we are, and we are because I am. And we have to be humble enough to ask for guidance, to ask for help, to work as teams. As teams, we will go faster, we'll go better. So we are all just parts of we are little flecks of dust in this universe. So I think if we are humble and we put the patient first, we put the patient at the center of our care, I think we will achieve a lot more. And in conclusion, the newer anti-diabetic agents, the SGLT2 inhibitors, the GLP-1 receptor therapies, they have better cardiovascular and renal outcomes and better outcomes generally, quality of life for the patient. There's an urgent need for healthcare practitioners, including pharmacists, to embrace the evidence, switch from traditional medication to newer therapies, screen for cardiac and renal complications. Early and timely referrals are vital. Diabetes remains a multidisciplinary approach. I've sung that song from the day I graduated. Look for hidden pitfalls. Refractory diabetes is real. Adherence issues. The medicine won't work if you don't take it. Embrace newer technologies like CGM, individualized patient profiling, patient education and empowerment. There's so much information out there, booklets, websites, patient support groups. So these are crucial. If a patient who is empowered, a patient who is happy is half the battle won, 3/4 the battle won. The art of glycemic control may be complex, but it can be simplified, and it's a real joy if you love what you're doing. So I believe pharmacists are crucial in management of chronic conditions and can have powerful impacts in terms of patient education, adherence, and outcomes. And in many countries in the West now, pharmacists are actually leading in management of chronic conditions because of what is happening. I wanted to acknowledge my father, Dr. Rasiklal Bhatt. He has been a pharmacist in many pharmacies across the country. As a little girl, he really inspired me that empathy towards patients, sharing information with patients can have huge impacts on patient care. And I think he really inspired me to have the empathy and multidisciplinary approach with patients. He's now retired in Scotland, but he continues inspiring me. So I had to put this photograph for what he has taught me. So to Dad in Scotland. And my last slide is the good physician treats the disease, but the great physician treats the patient who has the disease. And that is, I'll stop slide sharing now. Thank you very much.
Right. Thank you so much, Dr. Achaya, for that insightful presentation. And I think I can see so many claps and love hearts coming from the audience. I think they really loved the presentation. So I think we'll quickly move to the next presentation by Duncan from AstraZeneca, and then we'll have the Q&A session.
Sure.
Duncan, welcome.
Thank you so much, Doc. So I'm going to share quickly my screen, and Dr. Acharya, thank you so much for an elaborate presentation. It was quite informative. So my name is Duncan Mwangi from AstraZeneca. We are a larger team when it comes to AstraZeneca. We have got two therapies, the oncology and the primary care. The primary care has got the respiratory and the cardiology. So respiratory, I know you are aware of our famous drug that is Symbicort. So for me, I usually do Forxiga. So I'm just going to share one slide because Dr. Acharya has shared everything that I wanted to say. So my name is Duncan Mwangi. I'm a medical rep in Nairobi, and we are all over the country. So when it comes to availability of our drug, it's readily available, and we have got a contact person everywhere in the country. So the drug that Dr. Acharya has talked about is the dapagliflozin. That is Forxiga, the original Forxiga. And just to mention, when it comes to diabetes, the first study was the DECLARE trial, as Dr. Acharya has mentioned, and it was the largest trial for when it comes to diabetes. It had 17,000 patients, 160. It was the largest and it was the longest, took 4 years. But since Dr. Acharya has talked about dapagliflozin being used for diabetes, and the results were, it showed reduction of hospitalization for heart failure, and also a reduction in progression for nephropathy. But what does this really mean to the patient? So last week on Friday, I had a meeting with one of the nephrologists, and he mentioned that the cost of dialysis per month for a patient is 80,000 for life. So for Forxiga right now, it's able to reduce the progression to CKD. And therefore, that means by those patients who are at risk, those patients who have got diabetes, if they're put on only this tablet, that is 10 mg, we are going to be reducing the opening of more dialysis centers in the country with just a 10 milligrams tablet. Also, this drug is also being used for heart failure. And you know the cost of hospitalization for heart failure. Just 1 week hospitalization is going to play a big dent to the patient. So this drug is able to do that. And it's only a 10 mg tablet. When it comes to the price, we reduced our prices sometime last year, by up to 47%. And the drug is, some of the facilities have them, but I know we have got so many public facilities that might want to have this drug for their physicians to use. And we have got this product available at Meds, and the price is quite favorable for the patient, considering what it's going to do for that patient. It is just a 10 milligrams tablet once a day, and it's able to reduce the progression to dialysis or to nephropathy, meaning that the patients are not going to go to dialysis, and also hospitalization for heart failure, at the same time reducing their HbA1c and thus managing their diabetes. So the product is Forxiga, 10 mg tablet, and that's all I have, Doc. Thank you so much.
All right. Thank you so much, Duncan, for that presentation, and also just for supporting this event.
Welcome.
So we're going to jump right into the Q&A, and Dr. Chai, I hope you're ready for the questions. We have 6 questions so far. So I believe, I think it would be best we tackle those considering the time that we have. So the first question is there a standard tool you would recommend for monitoring the quality of life for people living with diabetes?
Okay. So for people living with diabetes, no, but the psychiatrists use a quality of life tool, which you can Google. But for people living with diabetes, I have my own, I have kind of made my own tool. So I use the glycemic control. I use their quality of sleep. I use appetite. I just ask them on a scale of 1 to 10, if 10 was the happiest you ever felt in your life and 0 or 1 is the most miserable, where would you place yourself? And if they are really miserable, then every time I see if I can improve that. And also ask them, are you having suicidal? If they are feeling really miserable, of course, I refer them to a psychiatrist or a therapist. If a patient flags up a desire to commit suicide, that has to be referred to a psychiatrist immediately. And sometimes there are telltale signs. You can see a patient is dressed very shabbily. They're not taking the medication. And this is someone who was very groomed before, and you see them declining, or they've lost a spouse, or there's a reason for them to be depressed. And then, of course, the sexual function. That's part of quality of life. So for diabetes, it's different to non-diabetics, but there are actually tools available which psychiatrists use for quality of life. So, and quality of life for one person is different to another person. So, if somebody somebody with diabetes has neuropathy, it changes their quality of life. So things like, are you in pain anywhere? Like, numbness and all that. So I actually have my sort of checklist for questions I ask my patients: their vision, neuropathy questions, sexual health questions, relationship questions. And because you have a social history on a patient, then and if somebody is stopping smoking, they might have added weight, that's affecting them. And then if I feel they need to be linked to somebody like a social support group, you need to bring in, loop in a family member, then I give them suggestions. This is a website, you can call this person, or I call in a family member to talk to. So a quality of life is not something, for diabetes, at least there are some standard questions you can ask, or you can make your own tool. So I would prompt every practitioner at least to have a few basic questions to ask. But I will tell you, most medical practitioners don't want that fourth star in the pentad to talk about quality of life. And mental health is another thing. Like, just how are you feeling? Do you sleep well? Do you eat well? How is your mood? Just the word mood, and you'll see the question looking at you and making eye contact and saying, this doctor cares about how I feel. So I think instead of just using what's available, like our culture is different in Kenya. So I think it has to be the culture of even the patient you're facing might be different. We see different races and ethnicities of patients. We have been dealing with the same patients for a long period of time. So you kind of make out what is the personality of that person. The quality of life of a CEO might be very different to the quality of life from a humble person who's coming from Ushago. They might be just happy if they're able to farm every day. The people who come from upcountry to see me want to rush back. They don't want to stay in Nairobi. Whereas a Nairobian is a different, if they can go, they want to go partying. A teenager's quality of life is different. Somebody with type 1 diabetes wants to go clubbing. They want to have the alcohol. So it's different for everybody. So I don't think you can get it off the internet. It's very individualized. And then you have to set goals. Okay, these are your goals. What is bothering you? How can I help you? Who can I refer you to? So it takes a little bit of time, but believe you me, even in terms of your targets, so there is what you are achieving as a physician, the sugar, the BP, the cholesterol, and all that, the weight, and then there is what you're achieving in that space, which is difficult to define, but which really impacts on the patient. So
Right.
it's a huge discussion. Yeah.
Sorry. Thank you for that, Dr. Chaya. And the next question is from Dr. Tracy, who is asking if there are any specific precautions when prescribing phosphodiesterase inhibitors to type 2DM patients with erectile dysfunction.
Okay. So first of all, with the phosphodiesterase inhibitors, like I said, some of them are actually good to prescribe on a daily basis if you think they have cardiovascular issues. So those you prescribe at a lower dose daily. But if they're going to take the longer acting ones, like the taldenafil, then they have a long half-life. They're in the body for 36 hours. So then you have to tell them that you can't take the higher dose, like the 20 mg or the 15 or the 10 mg for the next 36 hours, because otherwise they will actually end up ending up in casualty with a very painful erection, or they'll get really bad headaches. Then they should also keep it 1 hour away from food. This is something the pharmacist can also give them the instructions. But again, besides a nasty headache, I haven't really seen anybody having a very bad erection. I think patients with diabetes are actually cautious and they tend to underdose rather than overdose. Of course, they can't take them with the nitrates. So you have to look at what else the patient is taking. Yeah. It depends again, which I wouldn't say that, oh, it can't be Viagra and it can't, I shouldn't use the word Viagra. We should use generic names. So you can pick which one you want to give. But they're really, really helpful. And then before you prescribe a phosphodiesterase inhibitor, you should actually do a baseline testosterone, because if the testosterone is low, a 9 AM testosterone, then it will not work very well. So then you might want to give the sustanon injection to the patient. So erectile dysfunction is a whole, Pandora box, but you do have to sort it out for the patient for their quality of life. Yeah. I hope that answers the question. But the precaution, of course, is that the patient should not be on a nitrate.
All right, thanks for that. There's a question from Dr. Geoffrey, who's asking, does pharmacogenomics have a role in long-term diabetic management, and how accessible could it be for the commoners?
It's expensive and difficult. By pharmacogenomics, I'm not, is it like genetics of a patient? I didn't hear you properly. Sorry, today I have a bad cold, so I'm having difficulty hearing.
Yes, pharmacogenomics.
So the genetics of a patient.
Yes.
Yes, so in Kenya, it's a bit difficult. We've been trying to do some genetic studies on our patients. Both type 1 and type 2 diabetes have HLA-DR associations. So yes, it does have a role. We can't choose our families, but it's very expensive and difficult to go looking for that. By the time a patient comes to you, they've already been diagnosed. So again, there is not much to be gained in terms of doing all those studies. So we don't do that. But if we are trying to classify and we're not sure of whether it's type 1 or type 2 diabetes, rather than doing the pharmacogenomics, we do things like C-peptide levels and the antibodies, like the GAD antibodies. I don't know if that's what the question was leaning more towards. But in terms of the genetic studies, we don't manage to do a lot. Sometimes we are not sure if somebody is type 1A or 1B, that's where it would be useful, but we have found it very expensive and very difficult to do the studies. I don't know if that's useful.
Yes, I think that answers the question. And there's one who's asking, what's your clinical experience with the semaglutide in achieving weight reduction among patients with type 2 diabetes? And how do you balance its benefits with the potential risks in long-term
Expecting
management?
that question. Nowadays, so many patients come book an appointment with me just to prescribe, they'll call it Ozempic or Mounjaro. These are expensive medications. They will work as long as they are used. There are patients in whom you can absolutely not prescribe them. So unlike America, where people can pick them up from massage salons and gyms, here we can't. And again, if somebody comes to your pharmacy asking for them, please ask them to see a medical practitioner. People with thyroid cancer, especially papillary thyroid cancer, should not be given semaglutide or even a family history of thyroid papillary cancer. People with gallstones, be very careful. Anybody with intestinal obstruction or risk of intestinal obstruction, even if it's an umbilical hernia that hasn't been picked up. So, and patients will not tell you because they're desperate to use them. Yeah. So there are absolute contraindications, and then there are relative contraindications. Some patients want to start with the highest dose, and they will suffer with the most horrible GIT side effects, the nausea, the satiety. So yes, I have used it in the patients who need to use it. So nobody should be put on semaglutide before they've tried everything else. So lifestyle, medical nutrition therapy, sometimes psychotherapy, exercise, behavior therapy. There are other safer agents to use. There is the Orlistat, there is other agents. And semaglutide, a lot of times my patients drop off because they can't sustain, they can't afford using it. Yes, it's cheaper than bariatric surgery, but is it? In the long run, if you calculate for how long will they use it, But sometimes it gives somebody a head start if they can lose a certain amount of weight in a certain amount of time and then continue. So it's a double-edged sword, but I have used it, and I've used it with supervision. And also we have to look at the cold chain. Where is it coming from? Is it a suitcase importation? Where was it acquired from? I don't know if the PPB has got it officially. I've not attended any official launch for it. I don't know, maybe you can help me answer. Where is the semaglutide coming from? I attended one launch that was at a hotel, which was for a generic semaglutide. So I assume they got their license.
All right, thanks for that. So there's another question from Dr. Edwin who's asking, how early should we start Forxiga in diabetic patients?
With all that's a question that's asked at every conference. Type 2 diabetes is a coronary disease equivalent. So in my opinion, this is my personal opinion, I feel it's not right to deprive a type 2 patient of it. That's my personal opinion. But again, the guidelines say somebody who has cardiovascular or renal, risk. But again, we all sing the song that a type 2 diabetic is a coronary disease equivalent. So in my opinion, every type 2 diabetic is a coronary disease equivalent. Somebody with impaired glucose tolerance is also a coronary disease equivalent. So I would be sticking my neck out and saying, I feel it's wrong to deprive people of it. And then when we wait till they get albuminuria, or they get renal impairment, or they get, heart failure, they get something happening, and then we are bringing it in, it's like closing the door of the stable after the horse has escaped. But then again, because, people say, oh, the price, but you look at the price of a heart attack, look at the price of renal impairment, the dialysis Duncan just talked about. So again, people are saying individualize. It's very difficult to answer this question, but it's a really, really good molecule. The prices have been reduced. So with tongue in cheek, I tend to use it earlier together with metformin, or lifestyle is there. So that's my personal opinion.
Right, thanks for that. So I see there's a question to Duncan, particularly on the price of Forxiga. Maybe you can just clarify on that, though I know you've been giving the response on the chat.
Well, thank you so much, Doc. So the price of Forxiga is 2,853 at Meds. That's where we have got the best access price there. But also our products are available at Laborex, Sagifarm, and also Eldobase. So if you contact one of those 4 distributors, you're going to get a Forxiga. And I've also shared my number and also my email number in the chat box. In case you need to reach me, it will be easier that way. So that I can also introduce you to my other colleagues that if you need more assistance on the same, because you usually work as a team at AstraZeneca. Thank you.
All right. Thanks a lot, Duncan. So I think maybe you can take 2 more questions, then we'll close. And there's one by Dr. Lynette who says, what is the role of fasting in improving insulin sensitivity? It seems to be touted a lot in the health and wellness space.
Okay, Lynette, thank you. I don't know if you meant intermittent fasting or just fasting. First of all, the keto diet is dangerous for anybody with type 2 diabetes. So I'm not in favor of, drastic fasts or keto diets. So people with diabetes should not totally cut out carbs. I know for weight loss, fat diets are not good. Intermittent fasting works for certain people, but again, the person should see a nutritionist and an endocrinologist before embarking on the 16-hour the very long intermittent fasting, things like fatty liver, renal issues, all that can flare up. So I think before somebody decides to go on long periods of fasting or intermittent fasting, they should see an endocrinologist or a nutritionist, or preferably both, because sometimes the nutritionists are also a bit lost. So they should at least do a fasting lipid profile, an HbA1c, maybe a fasting insulin level, renal function, LFTs. And I was actually expecting questions on fatty liver, but I guess it's okay if they didn't come up. So you look at a metabolic profile of a person, look at the waist circumference. Like I said, at the moment, the world is going towards waist circumference rather than BMI. So individualize, and then the person fasts safely if they need to fast. Many nutritionists will actually, the ones I work with especially, they are more in favor of food portions and sensible, diet plans rather than just fasting. But saying that, Professor Mike Lin, who I worked with in Glasgow, did have some diet plans where the caloric intake was quite reduced. It wasn't fasting, but it was low calorie diets. And that helped people to lose weight who are struggling with obesity, even some type 2 diabetes patients. So I think, again, it's very individualized, but you need to look at the patient's renal profile, the liver profile, the HbA1c. Some people even go as far as looking at there is something called the thin fat person and the fat thin person. So somebody could be slim, but they have a lot of visceral adiposity, and somebody could be obese, but they don't have that much visceral adiposity. And that is where the brown fat and the white fat tends to be used up. So you have to be careful about especially the duration of the fasting. I hope that is useful. Yeah.
Yes, thanks a lot. Then the final question is from Dr. Joseph Kadare, who says, just a compliment, how do you consider collaborative practice between the physicians and the pharmacist on medication therapy management reviews services as a critical component in improving the quality of life? A number of patients present with uncontrolled sugars, mostly because of little understanding of the drugs they take, how they work, and the expected adverse effects. Could you champion for bedside collaboration practice model with the pharmacist? And how do you get comprehensive medication review reports for your patients?
Thank you for that. I would love to be part of this. I don't know if Astra can help us come up with something, or one of you can. This is something I've been thinking about for the longest time. I think we need to work together. I don't get a CMR. I do at the hospital where I work. Sometimes the hospital pharmacist will call me and say, blah, blah, but this is very patchy. So I think if we can come up with a document or something, I would be really happy to. It's not just uncontrolled sugars. Compliance adherence is a big issue. One of the theses I supervised at University of Nairobi was on compliance and adherence of anti-diabetic medication with one of my postgraduate students. The problem with thesis is once somebody gets through, they don't publish. So maybe it's something we could take up again. So it's not just uncontrolled sugars, are the patients taking the medication. Sometimes it's not even due to adverse effects, it's due to costing, it's due to other factors. Availability, accessibility, side effects. So I think it would be a wonderful thing to look at here in our country.
All right, thanks for that response. And I think that's something we'll follow up with you, Dr. Achai, just to have a conversation on that.
Sure,
So I think that would be the last question for this session, because I see we are running out of time. So I'll just allow you to give a parting shot. Then we can also have Duncan to give a parting shot, and then we'll have a few announcements, then we close.
My parting shot would be that I think diabetes is a lifelong and multidisciplinary condition, diabetes and the NCDs. I think we can all make a difference, make a lasting difference, and make a good difference in the lives of our patients. We need to network, we need to talk, we need to really reach out to each other. I think the pharmacist is a very important caregiver to our patients. And I think let's keep this conversation going. So I'm really thankful to have been part of this meeting. I'm really humbled at the numbers that have turned up despite Easter tomorrow, and happy Easter to everyone. So I look forward to more collaborations in the future. Thank you.
All right, thank you so much, Dr. Chayo. Duncan?
Thanks, Asma.
Thank you so much, Dr. Hezron. And thank you so much for that presentation, Dr. Acharya. It has been quite informative. For me, it's just to pass the message that AstraZeneca, we are here to partner with you when it comes to capability building in our products, like we have done today for Forxiga. And these life-changing medications, they're available, and you have made them accessible all over the country, and you've got medical representatives all over. And if you feel like this tablet Forxiga, it's only a 10 mg tablet once a day that is going to give a life-changing difference and improve the quality of life for your patients who have got diabetes, for those patients who have got cardiorenal risk. So in case you need to contact me, my contact is it's on the chat box, and we can always get this medication available all over the country so that we can change the lives of our patients. Thank you so much, PSK, for this platform. It has been quite engaging, and I'm happy for the attendance. It was quite good. Thank you.
All right, thank you so much, Duncan. And once again, Dr. Chaya, thanks for that insightful presentation. AstraZeneca, Duncan, thank you so much for the support. And we definitely look forward to having more sessions with you. So as we close up, members, I'd like to remind you, if you've not, kindly ensure that you subscribe to the event on the PPB portal. Use the keyword T2DM, and you should be able to find the event easily. Just a reminder of an upcoming session that we'll be having next week on Tuesday. This will be on just an introduction to research methods for pharmacists, and we'll be having Dr. Michael Mungoma, who will be presenting on this with the support of Professor Calvin Andeve. Then also to remind you that our annual conference will be happening soon, 2 months to go. So if you've not booked your tickets, kindly do so. Just visit our website and take advantage of the regular bird ticket. Remember, we had the early bird ticket, which ran out end of March. So the regular bird ticket deadline is 30th of April. So ensure that you take advantage of that before we move to the next ticket class. A reminder, for those who will be interested in submitting their abstracts, kindly do so. The deadline is also on 30th of April, which is on a Wednesday. So if you haven't, ensure that you submit your abstract on time. Then finally, just a reminder that when you're reporting your adverse side effects or poor quality health products, kindly use the 3 options that have been provided by the Pharmacy and Poisons Board. The first one is the pv.pharmacyboardkenya.org, which is the website. The other option is the mobile application, where you can find it on the Google Play Store or the Apple Store. Both the first 2 options are for the healthcare professionals. And finally, the last option, which is the USSD code *271# is for the members of the public. So once again, thank you all for joining. Thanks to our speaker, Dr. Chaya. Duncan, once again, thank you. And for all of you who've been able to attend today, thank you so much. And sticking up to the end, kindly ensure that you subscribe. Don't forget to do that. And have a happy Easter as you travel and enjoy the holiday. Thanks a lot, and have a good evening.